Welcome to this brief review of Module 12. We'll hit on two major topics, the final project and, of course, the homework for Module 12. Originally going to talk about the homework for Module 11, but it looks good so far, so I don't think there's anything to comment regarding that. In terms of the final project, it's still important as soon as you can to let us know, are you an on-site student or an off-site, so that we can build the teams. It would be helpful if you would fill out the project planning roster. Click on this link and it'll take you to a spreadsheet where you can indicate if you're on-site, off-site, and if you have access to the labs. We're certainly going to need for the experiment that we're going to conduct not only access to the wet lab, but we're going to need access to the electronics lab. That would be Wickenden 301 and Wickenden 302. So once we have the teams established, then it's really about finding the available lab times. It looks like from the lab schedule, we're pretty likely to have a lot of free time if you're available Fridays after 6. And we'll start with a session on Friday the 18th of April. And certainly all day Saturday on the 19th or the 26th is also available. So once we get the teams built, then we're going to go ahead and offer slots for conducting these experiments. The details and everything you need to know about the experiment, the lab, are on Canvas, so just download and preview, and maybe even want to plan ahead with your partner. This is, of course, a classic experiment. This pH measurement is not anything that unusual, and you may have seen it before, but that's okay. We're using it because it is a straightforward experiment, and it does really give you some hands-on activity, and it can be done quickly. Time is passing, so with the time remaining in this semester, we feel everybody can be successful with this lab experiment. The textbook for this module turns out to be pretty valuable. The subsections are really not too long, and they often have pretty focused presentations. In particular, we're concerned with 10.6 and 10.7. Certainly the blood glucose sensor is a huge impact clinically, and of course our Module 12 homework is going to be centered on the pulse ox, which is about blood gas monitoring. So again, sections 10.6 and 10.7 will be valuable to you. Not trying to have too much reading, but a little bit of reference material can actually help you in your journey. Also, I've posted a video for the Michaelis-Menten equation, and the Michaelis constant is sometimes a little confusing, but this video is short. It's a 5-minute video, and it goes through a lot of discussion of the equation and its value. Because sometimes when we blend chemistry and sensors, it can be a little bit of a challenge, and I think videos like this do a nice job providing clarifying remarks. Blood glucose sensing involves mediated reactions, and section 10.7 of the book on the blood glucose sensors is actually very readable. Again, this is from Webster, starting on page 485. The description goes through the idea that you go from glucose and with water and oxygen, and you get this glucose oxidase that eventually spins off electrons that are picked up on the electrode surface, and that's what you would actually measure. So the descriptions provided in the textbook are pretty good, actually. And once again, I'm not trying to have too much reading, but I think if you were to skim or dig into the first few pages of Webster 10.6 and 10.7, it'll provide you a lot of insight on everything that's going on. And particularly when you want to review these reactions, that there's a series of reactions that are actually quite fascinating to look at. But in any case, they are the foundation of blood glucose censoring, which has really been essential in the diagnosis and management of diabetes. So it's an important sensor that affects a lot of people's lives. So it's worth a read to have some insight on that. The topic of binding equilibria is important with glucose sensing because it impacts the accuracy, sensitivity, and reliability of the sensor's measurements. These are all the parameters that, of course, are very, very important in sensor design and optimization. These are probably not much of a surprise to most of you, but basically the equilibria, the glucose sensors rely on very specific binding interactions between the glucose molecules and the sensing elements. So in this case, the sensing element would be the enzyme, and that helps with the detection of the glucose levels in the biological samples like blood or interstitial fluid. So again, we mentioned that it's really important to understand the binding because it affects accuracy, sensitivity, selectivity, response time, longevity, and stability. Okay, these things don't last forever. They have a shelf life, and of course, how you calibrate them. The homework for this module focuses on pulse oximetry. I think this should be straightforward. The pulse oximeter is a very common device you find in many clinical settings, and it operates really based on the principles of light absorption and the behavior of the oxygenated and the deoxygenated hemoglobin in blood. And basically, the purpose of this assignment is to provide an opportunity to understand some of the basic instrumentation principles in a device which is very, very commonly used in clinical practice. Again, I encourage you to take a look at the textbook, Webster 2010, specifically section 10.6, starting on page 479. This is a picture of a typical finger pulse ox, which some of you may have seen. Very small. We're amazing at these things. You can get them off the internet for $25 or less. It's really a remarkable stride in terms of commercialization of sensor technology. An excellent paper to refer to, in addition to or in place of the section 10.6 in the textbook, is this paper by Chan that was published in Respiratory Medicine in 2013. It's really focused on pulse oximetry, but really it's focused on the basic principles, and it was written like that so that it would facilitate the appreciation of the limitations of pulse oximetry. There is some controversy associated with pulse oximetry because in the end, even though we have some rational ratios of oxygenation curves, we still need to calibrate that, and some of the calibration coefficients have been somewhat controversial. Specifically, it relates to melatonin levels in the skin. Again, this paper is highly recommended, even if you just scan the first couple pages. Certainly, there's many pages articles out in the market, so just go out there and take your pick. You can go into PubMed and search really quickly and get a meaningful resource. But basically, I like Chan because it does a really nice job explaining a lot of aspects of sensor performance. While you may have seen this before, a pulse oximeter works by measuring the oxygen saturation level of blood in a non-invasive way. This is critical because the non-invasive nature of it has made it extremely popular in the clinical setting. In a simplified perspective, the operation involves light emission from light-emitting diodes, light absorption, and that light absorption is reflected in a photodetector. So basically, the pulse oximeter emanates two wavelengths of light, red and infrared. That's because the different types of blood absorb it differently. And basically, the wavelength of light is emitted into the body part being measured. So we would now commonly think of the finger probe. That seems to be the most popular one. But also popular is the earlobe sensor. And in fact, it's interesting that in the very beginning, it was the earlobe that was designated or determined to be the site where they made the clinical correlation of the oxygen saturation. When we talk about other suitable body parts, this is anything where we can pass the light through. And interesting enough, in pediatric, it happens to be the foot. Kind of a surprising point there. But essentially what happens is oxygenated hemoglobin and deoxygenated hemoglobin absorb light differently, and we take advantage of that in this measurement system. So while the oxygenated hemoglobin absorbs more infrared light, the deoxygenated hemoglobin absorbs more red light. So we take advantage of those differences in absorptivity in our calculations. But essentially what happens is that from a calculation perspective, to comment quickly on the calculations involved, what we're really doing is comparing the intensity of the red and infrared light that reaches the photodetector. Okay? So the pulse oximeter determines the ratio of oxygenated hemoglobin to the total hemoglobin in the blood. And that ratio, again, so we're going to have a ratio of ratios here in a minute, we'll see, is used to calculate the oxygen saturation level, which is expressed as a percentage. There'll also be a calibration coefficient in there, which would also have to be established. But essentially, in addition to being able to determine the difference in the ratio of the oxygen saturation levels, we also get this idea of the pulse measurement. So the pulse oximeters also measure heart rate. That's because the arterial blood moves in a pulsatile fashion associated with the systolic and diastolic contraction of the heart. And basically what happens is the blood flow we measure is in sync with the rhythmic changes of the blood flow in the tissue from the heart. And so these changes in the blood flow, in the light absorption, are actually used to determine the heart rate. So you just count the pulsatile and you can figure out what the heart rate is. Also, more recently, with sophisticated algorithms, we're actually able to take what's called the heart rate variability, and with some calculations are able to actually massage this to determine what the blood pressure is. Now that's sort of a non-intuitive thing because you think of the blood pressure as something that has to be mechanically measured. And of course, this is an indirect measurement, so there are some calculations, but over the last few years, these calculations have improved in sophistication, and they're actually pretty accurate. So basically, the way to look at this, the pulse oximeter provides a quick and non-invasive way to monitor blood oxygen saturation and the pulse rate versus the central venous catheter, which we'll talk about in a second. The PowerPoint slides may make things look pretty easy, but the history can reveal a lot of insight as well. It really wasn't until 1876 that it was recognized it was a change in pigment in red blood cells when combined with oxygen, and furthermore, that the cells without oxygen absorb light differently than blood cells with oxygen. Okay? So on top of that, it was realized that as the blood flow increased, reflected light changed as well. So this created two measurement opportunities. First measurement opportunity was that different wavelengths of light actually have different absorption levels, and this could be correlated to blood oxygen content. Second was that the reflected light is also a marker of blood flow and its changes. And so essentially what happens is that the reflected light is recorded as what we call a photoplethysmogram, PPG, but still, you record that, but the data does require interpretation to be useful. So nonetheless, a lot of this happened in the 1870s, but it wasn't until 1935 when Millikan and Wood explored the idea of the earlobe as a way of passing the light through that tissue, and that's when the clinical significance of the system became correlated to oxygen saturation level. And this is when really sort of launched the non-invasive technology. Of course, the problem was that there was still this pulsatile nature of the blood flow, and it really wasn't until the sophisticated signal processing techniques of the 70s were in place for the pulsatile nature of the signals and what they meant in terms of oxygenation and calculations actually came out. Again, just in case you thought things were easy, we actually have 4 different types of hemoglobin. We've got the oxyhemoglobin, deoxyhemoglobin, carboxyhemoglobin, that's the carbon dioxide that's attached, and then the methemoglobin, which relates more to the iron content. But basically, there's different absorption spectra, as we talked about. The coefficients are different. This coefficient on the y-axis, it's we say absorption and it says extinction coefficient. Extinction is kind of an odd word in this case, where it really means it's more of an umbrella term, which includes the diffuse nature of the light and in terms of that which is absorbed. So it's a little bit more comprehensive. Actually, I should have just struck that out altogether. So absorption coefficient. Basically what happens is the coefficient of the 4 different species of blood are shown on the right-hand side. And notice that some of these have some very similar paths. So the carboxyhemoglobin and the deoxyhemoglobin really react to light in a similar way, red light similarly, and you see the crossover term here for that particular frequency, and same here. So we take advantage of the very specific wavelengths and the coincidence of crossing of the curves in our calculation sequences. One thing to mention about the homework is that you may have to identify a few pulse oximetry issues, and for that I refer you to the paper by Chan, the 2013 paper. Table 1 provides a lot of examples, and you just have to pick a couple of these to mention for the homework. So again, just a hint, this is a great resource to use when you get to solving the problems for the homework for Module 12. The alternative to the pulse oximetry, which is non-invasive, is the central venous catheter, which is invasive. And what you do here is you place a catheter into a central vein, okay, such as the superior vena cava or the right atrium of the heart. This catheter is equipped with sensors that can directly measure the oxygen saturation of the venous blood as it returns to the heart. It is a more direct and accurate measurement of oxygen levels. This would occur through one of the lumens. Typically in a central venous catheter, you're going to have three lumens. One would be, of course, for the measurement. There could be for injection of medications or solutions or central venous pressure. But in any case, this is very important when you have critically ill patients that are undergoing surgery, and close monitoring is really essential. It certainly is more invasive than a finger pulse oximeter, but actually it provides the detail that's necessary. So once again, pulse oximetry is non-invasive and convenient, but it's not going to be the standard of care in all situations. Just to get on with the discussion of the homework for Module 12, this is again on the pulse oximetry. This should be straightforward, hopefully, and there's really basically 4 parts to the assignment. The first is to create a multi-sim model of a pulse oximeter. You don't have to create it from scratch. You can if you wish, but there are a bunch of these that are available through a web search. Basically, all you have to do is find one out there, a multi-sim model, identify it, and describe the key features of the major components. And of course, when you do use something from the internet like this, you do want to note your references. So you're going to find the model, identify the key features, then you're going to go ahead and implement the model in multi-sim, and then conduct some exploratory parametric variations. In this case, you might vary the frequency of the sensor to represent differences in heart rate, things like that, but we'll talk about that in a second. And so then after you implement the model and you conduct some exploratory parametric variations, then simply summarize the results and comment on the significance. One comment to make is that if you cannot get the model you choose to work, and sometimes that's the case, not everything on the web is going to work the way you would, then simply don't go down a rabbit hole. Take the modeling to a logical point and then simply discuss what you'd hope to accomplish. So we don't want you to be sinking 20 hours into something that should be actually pretty straightforward. So again, find the model, try to implement it, do some parametric analysis, summarize the results, and to the extent that you can, get some results that you can describe. I would have to say that once again, Chan, the 2013 paper, can help you with the homework discussion on basic things like what might happen with falsely low SpO2 and different parameters that are not necessarily obvious. But again, these are some pages. There's not that many. It could be like, half a dozen pages here. If you read them over, it could be very, very informative as you do your write-up for your homework. Basically, again, the oxygen measurement, this is described in Chan, the 2013 paper. And really, this is to come back to something I mentioned earlier about the sort of the steady state sort of blood flow. And there's the blood flow through the venous and capillary blood actually tends to be pretty stationary as composed to arterial blood, which reflects more of the systolic and diastolic motion of the heart. Of course, that's due to the ventricle contraction, as you see on the QRS sign here. That, of course, is the depolarization of the ventricle, which leads to the contraction and produces the systolic and the diastolic motion. What happens is, again, you can take this sort of pulsatile motion, and again, going back to some of the analysis from a long time ago, in the 70s, the algorithms enabled us to sort of tease out what was most important. This figure over here gives us a great diagram that really compares systolic and diastolic changes of the capillary or vein and comparing to the artery. And so in the case of the so-called DC component, it's very difficult to tell between systole and diastole, but in fact on the artery it's a little bit more distinguished, as we show over here. And so basically what happens is there's these changes in red light absorptions and changes in infrared light absorbance. And what happens is you take the ratio of these, and the ratio of these actually correlates to oxygen saturation. Kind of a clever thing, and does, of course, involve as you can see over here, it involves a ratio of ratios, which can be just a little confusing. But not only do you have the ratio of ratios, but this has to be calibrated. And again, as I mentioned earlier, it's some of the calibration curves and constants that are used that are sometimes open to debate because they aren't necessarily comprehensive for all types of skin color and tissue types. But basically, you're going to go ahead and find a multi-sim or create a multi-sim pulse oximeter. Like I said, there's a lot of examples out there on the internet, and those can be used to jumpstart your effort. There's no shame in using what somebody else has already produced. Of course, reference it properly. And basically, if you want to create a diagram of your own, that's fine. That's okay too. But really what you want to do is to get some sort of working model and then go ahead and modify some parameters. And in my case, what I've used here is one from the multisim.com. It's available off the internet. But essentially what happens when I talk about varying parameters, you want to, one thing you might do is to modify the photodiode output, and that would be represented over here. So you've got the current output and the frequency from this photodiode output. And you could change things like the frequency to represent different heart rates or different amperages to represent different perfusion of the tissue. So you play around with these to sort of represent tissue perfusion changes and heart rate changes. That's one thing you could do. You could also fuss about with a high band filter or high pass filter, and then of course you've got the resistive and capacitive components associated with the high pass filter. And you could change these parameters to see how it would affect the results and what you are filtering out and how it impacts the output. And of course, then there's amplification. You could do different things. This is a simple op amp, and you've got two amplifiers here, but you could play around with those parameters to see how they would impact the output. So it's pretty straightforward. And like I said, please try to take advantage of what's out there. Work on this for the purposes of providing insight and clarification. We don't always have to start from first principles to learn. With that, that's sort of the end of the review. I would encourage you, have any questions whatsoever, to possibly reach out to myself or the TAs. My email is cxd@case.edu, and I am pleased to answer any questions or comments or criticisms of any sort that you may have or help you with clarification. So when in doubt, stay in touch. Thanks.